Thanks for the introduction. Congratulations to all the organizers for organizing such a wonderful meeting post-COVID and for seeing such a large attendance. And also thank you very much for inviting me here. And it's an interesting topic, why UK should embrace robotic bariatrics. So I shall try and share my experience of robotic bariatrics in India. So we've always had resistance to new technology, and that is something that has been historical. And I also remember when I was here many years ago at Charing Cross Hospital. This was in 1992. I was working as a career registrar there, and that's when we started doing laparoscopic surgery. The first lap cholecystectomy was done this year at my hospital there. And in those days also we used to see these kinds of publications. So these are some publications which were visible in those days, and you could see how there was a lot of skepticism and resistance to a procedure which now is considered gold standard. So there are various reasons why UK should embrace robotics, and the first foremost reason is UK has been world leader in innovations, technology and newer procedures from ancient times. In fact, this is the Pro Robot, and this was something that was started in UK at the Imperial College London. So the UK has been pioneering in this technology. Then again, even after the Da Vinci robot and the Intuitive has been there, we've seen this robot which has come over from Cambridge, and the Versus robot. The great advantage, as you can see there, are the arms which can be individualized. So you don't have a single robot, the arms are separate, and you can see how small, with a small full footprint, this is there. Interestingly, we've got 24 installations of this UK robot in India compared to 7 installations in the UK. So India is a good market for this robot, and I should think that it should be used more and more in this country too. The second reason is I can do everything laparoscopic, so why do I need to do robotic surgery? That has been a question for a long time by surgeons. So yes, I would agree there that there are surgeons who are very skilled and they can do everything laparoscopic, but we are talking about a technology which can raise the standards of an average surgeon. So a very good example here is that at my hospital we have a senior gynecologist, and I used to help her with laparoscopic gynae surgery. And she used to call me for minor procedures, ovarian cysts, etc. When the robot came and when I started robotic surgery, one day she came to me and said, "Arun, why don't we try this on myomectomy? Because you can suture the uterus very nicely with the robotics." So we went ahead and we did a few myomectomies. After that, one day she said, "This looks quite easy, can I try and suture?" So yeah, she went ahead and sutured. After that, I stopped getting called from her, and a month later or so, I met her in the corridor and I said, "Ma'am, what happened?" She's quite senior. "You've lost your enthusiasm?" She said, No. We have been doing it. If there is a problem, we'll call you." So the message here is that someone who all these years would not try to do laparoscopic suturing or a laparoscopic gynae procedures on her own was able to pick up this procedure and proceed with it. So all I'm trying to say is that this raises the standard. So yes, you can have a few super surgeons in the country, but everyone cannot be a super surgeon. And there would be surgeons, and the best example from bariatric point of view is there would be a lot of surgeons who are comfortable doing a sleeve gastrectomy, but they would be reluctant to make a small pouch close to the diaphragm and suture it. Here comes the help of the robot, which can raise standards. So this is a small clip, mostly external view, and this is a super obese patient weighing about 250 kgs. And the robotic procedure we are doing using an intuitive Da Vinci XI system here. That's the console which is there. It's like a, like a Mercedes really. You can prefix your preferences there, and you've got the view. All the settings can be done. We look into the console through what is a true binocular vision. So it's a true 3D vision because it's binocular. There are two separate cameras. It's not like wearing the 3D glasses in the movie halls. Then we have foot controls. So the right foot can control two instruments, energy devices, cutting coagulation, while the left foot controls the camera, it controls a clutch, and it also controls the switching of the instruments. It looks complicated, but it's no more complicated than driving a car. Just like after learning how to drive a car, you can drive from your home to hospital without even realizing how many times you change gears. These are the instruments. You can see how there is a 360-degree finger movement, which is literally impossible even in open surgery because my fingers can only move in one direction. So we get that kind of an advantage in complex areas, so something close to the diaphragm, revision surgery, pelvic surgery, that's the area where these movements help you a lot. The trocars are 8 millimeters. The telescope is also 8 millimeters. It has autofocus and auto white balance. You could use this telescope even to put in laparoscopic instruments in case you need. So it can be assisting you also. This part is what is the wheeling of the robot, where the robot is brought to the head end of the patient. So that's the head end of the table. The robot can move up and down, it can rotate, all these arms can rotate to the desired position. Then this is a process which is known as docking of the robot. It comes from Star Wars and Star Trek where docking takes place. And that's basically connecting the robotic arms to the trocars. And then the control shifts to the console, whereby there are circular movements inside the chip which gets translated into linear movements. So that's the bariatric surgery in progress. And the next part of this is, that's a slave following your commands. The next level comes an artificial intelligence level 1, whereby we use these robotic staplers which has sensing. So when you put in the cartridge and you apply the cartridge, it senses the thickness of the tissue and tells you whether you should be using a green cartridge or a blue cartridge. It will not fire the wrong cartridge because it is able to sense. And as you will see during the firing also, when it reaches a stage where it requires compression, it will compress. So if you see arm number 2 is where the stapler is shown. So that's clamping done, ready to cut. It's showing the cutting. Then it pauses for compression there. After the adequate pause, again it moves forward and cuts across. So it has this AI built in there, something which we have been visually trying to gauge during our laparoscopic procedures. There is data. There are studies which have been there, close to 2,000 cases in each of these studies. What did they conclude? The first study found no difference in complications, stage leak, bleed or stricture. The second study showed no leak in robotic, 3 leaks in the laparoscopic group. The third one showed less stricture rates in the robotic group. And personally, I feel that apart from the leak, the stricture rate and the bleeding is reduced because the suturing which you are doing by manually. Then we have the study which is from Switzerland, talking about the comparison of the costs. And this showed how once you get the complications, ICU stay, readmission rates and all that cost included, that they found that overall the gastric bypass was cheaper to the laparoscopic and open surgery group. In fact, they found that compared to the open as well. So the conclusion here was that the robotic RYGP can be cost effective due to balancing greater robotic overhead costs with the savings associated with avoiding stapler use and costly anastomotic complications. Another one, it's a long paper there, I don't know how to go through it. Then we have newer robots which are bringing down the cost, like the one I mentioned, the UK robot which is being sold in India. It's about 1/3 the cost of the intuitive robot. So many centers in India are taking up the versus the CMR robot. And this is a Hugo system. They are all similar. Then we have another system. This was something I saw in the US at Duke's. And the last one is a robot which is being made indigenously in India. It's an SSI robot, which is going to be even cheaper than the rest. So the cost is going to come down as time passes, as we have seen with mobile phones or any other technology for that matter, once the monopoly is gone. Now, the fifth advantage which I talk about, you saw a view of the stapler there. Now you can see how this stapler can move in 360 degrees, because this is being moved by my wrist. So when I'm holding the control with my wrist, I can move the stapler around. Something which I always missed, whether it was Medtronic or Ethicon or any of the other staplers, because there you needed two hands. So you have to articulate, again you need two hands. If you have to articulate inside the abdomen, again you need two hands, one to pull the flower and bend or to twist. So that advantage is there, because you can see my right hand is moving normally and my left hand is moving the stapler. Again, there is no difference of right and left in the robotics. You can use your left hand as equally well as you use your right hand, and you don't have to be ambidextrous for that. So when it comes to making a pouch, you can see how all movements are controlled. So I can, with my wrist, rotate it, move it up, down, sideways. All angles are possible. So the degrees of freedom which are there. And finally, as you will notice, you might have noticed in the video earlier also, that when the stapler is being fired, there is absolutely no movement of the stapler. I have found, the regular laparoscopic staplers, when I'm firing, it waves. We call it snake-like movement. And you're always scared that, is it going to damage the tissue? But here you can see it's absolutely rock steady when the firing takes place. You can see the yellow line there, which says firing, unclamping. So you didn't even notice that the firing was taking place. That's the kind of steady movement which it shows. ICG is present with my index finger. I can click anytime and I'll be able to see the vascularity. ICG is very easy to use here. Then this is something new that is coming through, where once the tissue is approximated, the system locks in. So it locks in and it's like an autopilot, and once the two edges are there together, the robot will be able to suture. So it's known as smart tissue autonomous robot, and that's something which is going to come next. Don't have clips for these. Single port robotics, this would be a great advancement, because the instruments would go inside and bend all around and be able to offset the problems which we were facing with sills earlier. As it comes to training, you can see this is a bus, a training bus which is there, which and our conferences, this comes to the venue. It's quite easy to train, and I would say I've been training my juniors for laparoscopy and robotics, and I find that they are able to pick up robotics much faster. I used to be pulling my hair trying to teach people laparoscopic suturing on endo trainers, and the same thing is much easier on the robotics. The dual console is there, like learning for flights or a car. Then lab versus robotic time taken is another area, and I compared 30 cases. This is after the learning curve, divided it into 4 steps. And if you see the chart there, the yellow being the robotic, The initial part and the last part, the robotic takes longer time, but when it comes to the crucial dissection and the suturing, the robotic takes less time. And now, after about, I would say after about 100 cases, my time taken for a robotic bypass started becoming less than the time taken for a laparoscopic bypass. Initially, it started with double the time. Another question somebody asked me yesterday that I heard it takes 45 minutes to dock. So here we've got somebody with the clock there. This is the video that is not running. Can someone come through? Yeah, it's running. So you can see that's the timer there, and I'm not trying to be very fast for the video. I'm doing this at normal speed. And again, I'm showing you the SI robot, which is the older robot, and this was in the earlier learning phase. So 2 arms have been docked. The third arm, here what we use a dual cannulation, where sometimes you can put a cannula in a cannula. This we used to do in the SI system, so that can be taken out and the stapler can be applied. And that's the 4th arm. So you could see that the total time taken is 45 seconds, not 45 minutes, what most people would think. Currently with the XI it's actually taking less because the docking is actually magnetic. You just put it there and it just clicks, like the Apple charger. So 10 reasons, some of them I've already gone through. And one reason which I like most is what I call as a Robo Lift. So you can see here, after starting the surgery, I've lifted up the abdominal wall, and you can shift. So a Robo Shift, you can shift the trocars, and then it will stay steady like that. Also, if you notice, the head up is hardly about 20 to 30 degrees. So my anesthetist is very happy, and also because of this increased space, you can use less CO2 pressure to get the same kind of exposure inside. Control of all 4 arms, something which we've all been wishing, and because you're heavily dependent in laparoscopy on your assistant. Now here you can see this 270-degree angulation of this instrument, which is great for any retro dissection. This is like the gold finger we used to use for gastric band. So that's the ease of retrofrontal dissection. This is an MGP OAGP procedure going on. Then there is very little torque on the abdominal wall. So people ask, how come the pain is less with robotic? You're using the same kind of cannulas and trocars. The reason why it is less is because the arms move around the fulcrum, the trocars move around the fulcrum, and that's why there is very little torque, both for the patient as well as the surgeon. So the surgeon also feels comfortable because there's less pain. Now, when we do the anastomosis, again, the steady camera and the steady assistant arm is what helps, in addition to, of course, the angulation of the instruments which I was mentioning. So that really helps. I think I'll skip that video. There are publications which tell us the benefits of the robotic digital interface, advantage of the 4-arm control. Yeah, I'm coming to the conclusion, thanks. So endo wrist movement, robotic suturing. So these are the problems which we face in high BMI patients laparoscopically, and that is what I tried to show how we could overcome. So coming to the summary of the advantages, deep head is not required, extra space the torque reduction, blunt angulation, steady loop during GJ, ease of suturing. So these are the technical advantages apart from the training and the standards which I had mentioned earlier. So personal advantages, I see advantage in revision surgeries and bariatrics in the super obese. So I'm not ready to say that robotic surgery is the future for our field. It's a good fit for specific procedures, not for all. However, using computer technology and advanced imaging to improve what we do for patients is absolutely the future of surgery, and the current generation of robotic devices is the very beginning of that revolution. So, new frontier, start your journey here. And finally, quote, change is inevitable, growth is optional. Thank you very much. Sorry for taking the next
That was a fantastic presentation, Arun, and I want to do it. And I see a lot of faces in the audience of super experienced surgeons who I think the same. Do you think a very experienced surgeon would get worse and slower before getting better? Is that a significant problem?
Yes, when you start, it is quite frustrating, because when I started, I had done lots of laparoscopic surgery, and it was quite frustrating because we were taking much longer. But after the initial learning curve, it does become easier, and other advantages as we grow older, it is going to be much more comfortable.
So I am old. Do you think it is not too late for me to start this? And some of my experience.
Absolutely not. I gave you the example of my gynecologist colleague. She was 70. Her age was 70 when she started the robotic with me in 2012. Now she's 80 and she's still active at my hospital.
Thank you very much. I don't think we've got time for further questions, or has anybody got a very, very important and short question? No, so
our next speaker is Dr. Stuart.